Welcome to YHTV's Magical Medical Tour, episode 16. Thank you so much for joining us today. I'm Christina Suzuma, and with me, of course, is our wonderful medical guide, Dr. Glenn Woolman. Hello,
Greetings,
Glenn.
and hello to you, Christina, and welcome to everyone to the Magical Medical Tour. I'm Dr. Glenn Wallman. I'll be your medical guide today as we travel through the healthcare galaxy looking for ways toward optimal health. How you been, Christina?
Absolutely super. It's been a very, very interesting time on the planet right now, isn't it, Glenn?
It certainly is. There's lots of energies going in a lot of directions.
You know what's been really exciting for me is I've been running into a lot of young medical students that are doing their residencies. And what's been really exciting is the way that they are speaking about what used to be alternative medicines. They are now really focusing on acupuncture and energetic healing. And it's just been really magnificent this week. I've run into like two or three of them. And it's like, wow, this is like a whole new paradigm shift that's starting to happen into holistic medicine.
I think it's been happening for many years. It's just happens on the rate of geologic time,
Mm.
except for those that really want it to happen, then it's even slower. How'd you
That's
sleep?
an interesting way to go about it.
How did you sleep last night?
How did I sleep last night? Oh, I think pretty good. I have a wonderful Tempur-Pedic mattress now that contours my whole body the way it should be. So yeah, I really good. And I believe that we work our 15, 16-hour days, so it kind of like puts us out by the end of the day. How about you?
I love my sleep every night, no matter what it is. I always have a good night's sleep, but I sleep, I think, longer than most people. In fact, speaking of that, do you know how long the brown bat sleeps at night?
The brown bat?
Yeah, each night,
Wild guess, 5 hours.
19. The African elephant, how long do you sleep? How long do you think that animal sleeps at night,
At night.
or whenever it sleeps?
Or whenever I was going to say, well, the brown bat is like, when
Right,
I
that's a
said
good
five
point.
hours, that was five waking hours as opposed to sleeping hours.
Right.
The effalump, huh? What does
Yeah.
the effalump do? Oh, 10 hours?
Three. And take a guess, you know that we sleep about 8 hours. The human sleeps about 8 hours.
Hmm,
Take a guess what animal sleeps needs about the same amount of sleep as the human.
a monkey.
The pig.
Oh, really?
Yeah, the pig sleeps about the same amount of hours as we do. The reason I'm asking all these questions is because our special guest today is a sleep medicine doctor. He's a colleague and a friend of mine, Dr. Andrew Binder. He's a specialty consultant in the Santa Barbara Sleep Clinic, and he's the medical director of the Ventura Sleep Disorder Center.
Hmm.
And I would like to introduce you to him now. Christina, I'd like you to meet my friend, Dr. Andrew Binder.
Hello, Dr. Binder. Welcome to our show. Thank you. You honor us.
Well, thank you for having me. I look forward to it.
Andy, usually as the medical guide, I like to tell our viewers kind of the direction that we're going to take today. And so I would like to share that with them for a moment. First, we want to get into a little bit of a discussion about your journey, how you decided to become a healer in general, what were the influences, what you did in healing, and then you took a leap into a specialty that was just forming at the time. This is another example of fields in medicine where specialties come up because people need them. And then I want to get into maybe a little bit of the history of sleep, talk about some sleep disorders, and then I want to end with some current diagnostic processes and maybe some newest cutting edge treatments. How does that sound to you?
Sounds fine. You lead the way.
Excellente. We'll all go on this journey together. So tell us, we look to in this program, we love to find out what is the heart and soul of the healer. So tell us why you got interested in becoming a healer and give us a little of your story.
Okay, well, I started out in college majoring in English literature and thinking that I wanted to be a professional musician. Uh, for, uh, Fortunately, I was always good in science. That came easy to me, science and math. Um, I soon realized that I wasn't good enough to be a professional musician, so I thought about teaching English literature, and one of my professors uh, told me how many years it took him to undo the damage that graduate school in English literature uh, did to him. So I guess I took my third choice and went to medical school. But actually, my older brother had 4 years ahead of me. He was in medicine, and I th- I basically I guess followed in his footsteps, so took different directions in medicine. So uh, after after uh, after college, went to medical school, and then I did 7 years of training in pulmonary and became a lung specialist and critical care doctor. Um, Along the way, a new disorder became evident, and it was snoring and sleep apnea. When we first saw this, we didn't realize what the cause was. We thought that most of these patients were very heavy, and we thought it was too much work to breathe. It took us a while to realize that they were having obstruction at their upper airway. At any rate, because I was a lung specialist, I thought I needed to know more about it. I drove up to Stanford to take a course in the mid 80s, mid 1980s. And I'd been on call the weekend before. I'd worked all week, and I literally almost killed myself making that drive from Santa Barbara to Stanford, Palo Alto. And the introductory lecture was given by the founder of our specialty, Dr. William Dement. He really founded the Stanford uh, Sleep Disorder Center. And he just gave a 30-minute lecture and talked about excessive sleepiness. And I realized that I was always excessively sleepy because I was sleep deprived, and it was an epiphany for me. I literally realized that nobody in my profession really knew anything about this, and it was very important. And it was at that moment I decided I was going to become a sleep specialist, and that's what I did. I continued to do critical care for 20 more years, but along the way, I also taught myself sleep medicine, read the textbooks, and I became. I think I was the 519th uh, doctor to take the American, what is it? The American Board of Sleep Medicine boards, and I had the sleep center that I founded in Santa Barbara was the 17th accredited freestanding sleep center in the country. So that's how I got started. I started from the ground up, never, and it's been a great trip ever since. I gave up critical care about 20 years. Let's see, no, 10, 12. Sorry, about 15 years ago. So.
Oh.
Any thoughts of going back into music?
Um, I'm embarrassed to say that I was a guitarist. I have a beautiful guitar that I've had since I was 13 years old. It's a kind of a collector's item, and I'm embarrassed to say I haven't been playing very much, but I do have plans uh, of actually getting back into it again. It's just so consuming when I play music. It's pretty much the exclusion of everything else. So when I was raising a family, it got increasingly difficult to take the time and work and play music. So, uh, but I think it's some of it's still there. There are so many great musicians out there. I'm really grateful that I didn't delude myself and try to compete with these other people who are out there.
Yeah. Will, William Dement wrote, what was it, The Promise of Sleep?
Yes, yes.
I think I think I read a statistic in his book after you suggested I read it that said that at one time they did a study and they said 1 out of 4 people fall asleep at the wheel of their car. You were talking about your drive up to Palo Alto or up to Stanford. 1 out of 4 people, which made me think that if you're on a freeway that has 4 lanes and you're awake, then it's possible that one of the other 3 people may be falling asleep in a moment as you drive.
It's absolutely true that this is a very scary thing. When you're if when we're on the 101 freeway here in Santa Barbara, driving sometime during a time when there's no traffic. In LA, there's always traffic, but in Santa Barbara, we have times of the day we don't expect traffic, like on a weekend. And when all of a sudden the freeway is totally blocked up, I will predict and guarantee that you will hear sooner or later that a truck driver fell asleep at 3 or 4 o'clock in the morning, and it was a single vehicle accident where he fell asleep, went off the road, and maybe killed himself, damaged a lot of property, tied up the road, and this happens all the time. So it's a very scary, thing, and I think people underreport how sleepy they are. Yeah, it's a big safety, national public health problem.
Give us a brief history of sleep medicine, and when did we start learning about sleep? When did it become a little more official? I mean, we've talked about sleep since ancient times. There's lots of literature, and throughout history, there's literature, there's stories, there's poems, there's limericks, all sorts of things regarding sleep and health. But when did we actually start the science? And tell us a little bit about that.
Well, I probably should have prepped more for this, but I think that in the 50s, when Dr. Dement was a research fellow working at Stanford, he was part of the team that figured out that dreams occur during REM sleep. And that was kind of the beginning in the interest of sleep, but it was more.
Would you quickly tell everyone REM sleep?
Sure. Sorry, rapid eye movement sleep. Thank you. We now know, or we have classified the stages of sleep as non-REM or REM, being rapid eye movement sleep. And 75% of the time we sleep is in non-REM sleep. And sleep is a very active and organized structure. Sleep is it's a function of the brain, and it's probably to help protect and preserve the brain. But so we cycle every 90 minutes. Ideally, we cycle into progressively long periods of rapid eye movement sleep, during which our brain is very active. We're dreaming. The metabolism of the brain is very high, but we're totally seeing images and things that don't exist. They're just in our brain. Our muscles, interestingly, are paralyzed. Our muscles are paralyzed, and that's to protect us so we don't act out our dreams, which would be dangerous. So when you see your dog or pet kind of whimpering and barking and look like he's trying to run, he or she is. The dog is dreaming about running, and they can't actually run because their body is paralyzed. And so that twitching is just a little bit of a breakthrough. And once they figured that out, they began to realize that that in growth and development, an infant, a newborn, spends 50% of their time in the equivalent of REM sleep and 50% in non-REM sleep. And as we move to our 20s, it gradually decreases to about 25% of our total sleep time. And that stays pretty constant through our lifetime, except with medications which affect things. And we don't I think once they started realizing that their sleep was not just turning a switch off, and that there was active processes going on, and there was an organization to sleep, they began to study it more. But it really didn't become a medical specialty until probably the mid 70s, and that's when we started realizing sleep apnea was a medical issue, and that probably. Up to that time, I think that neurologists and psychiatrists were heavily into sleep, but it was a fringe specialty. And I think when the pulmonary guys got involved in it, and it was something very concrete, like you stop breathing and you may die, then people started paying attention to it. And I think that's really what launched interest, and it's the way a lot of us got into sleep. I will admit that the sleep apnea, while it's a major the major portion of interest in sleep, I find all the sleep disorders, which we'll talk about, touch on, fascinating. And for a pulmonary guy who didn't do a lot of neurology since in my early years, I had to relearn a lot of things and plus new things. So for me, it's been incredibly stimulating. And sleep affects everybody. I mean, every animal sleeps. Um, and I think I might just add that in our 24-hour culture where the lights are always on and people are always working all shifts, um, people get the idea that sleep is optional or you can train yourself to do without it, and that's really a myth. Um, Animals sleep, and for animals, it's dangerous to sleep because they're out in the wild, and when they're sleeping, they can get eaten. So they develop very elaborate uh, protective mechanisms to protect their time sleeping. They haven't evolved to do without sleep. Instead, they've figured out a way to preserve the time so they can sleep. So it's as necessary a function as eating or drinking.
Yeah, that's true. And much of the information it seems that we have about sleep is watching animal behavior, I believe. Tell me tell us about you mentioned the 75% non-REM and REM. Just so that everyone has an example, can you just kind of draw a mental picture for everyone of the entire night cycle of, say, an 8 hour sleep where you go to sleep and then you go from a beta to an alpha to a theta, and then you come back up again, and go through a cycle with us so that we have an idea of what sleep happens?
Sure. Well, we define the sleep stages, first of all, as you were mentioning, by the brain waves. And brain waves they're just little ups and downs, oscillations, and the amplitude, that is the height of the brain waves, and the frequency, or how wide the waves are, really defines what the waves are. And the sleep stages are defined as the predominant waveform. I won't go into the details of the waveform, but non-REM sleep, deep non-REM sleep, which comprises about 25% and of our sleep, and 50% is kind of intermediate non-REM sleep. When we're awake but relaxed, we're in the brain waves are alpha waves, and and as you go to sleep, the brain waves slow down and the amplitude gets higher, and we transition into, we used to call stage one, now it's called N1 for non-REM one, and then we quickly transition into stage two sleep, and that's where we spend 50% of our time. In the beginning of the night, we go into deep non-REM sleep, which is called now N3 or stage three sleep. And these are where you have the deepest sleep. It's characterized by what we call delta waves. This is like your brain in general anesthesia. You are like really asleep. And everything does slow down. And that is really seen mostly in the first part of the night, the first third, first 50%. As we get older, our ability to achieve and maintain a deep sleep actually does decrease. That's one of the aging processes. Um, and then we cycle up back into and then we go into our first REM stage in about 90 minutes, anywhere from 75 to 90 minutes. And it's relatively short, maybe 15, 20 minutes. And then we cycle back again. And then we have about 4 or 5 of these cycles. And we usually end up the second half of the night where we spend most time in lighter non-REM sleep, that's stage two. And we usually wake up, if we're in sync and with a regular schedule, we usually wake up from a dream stage. And the last REM period, the dream stage, is the longest one. And that's usually the one dream that people remember they had. In other words, you won't remember your dreams unless you wake up from the dream, and you won't be able to retain what you're dreaming about unless you make an effort. In other words, you'll remember you were dreaming, and it's very vivid, but But if you don't think about it and try to tell somebody or make an effort to remember it, suddenly it's gone. It goes from volatile memory into and it's gone. Whereas if you make an effort to try to remember it, you will be able to remember it and put it into your more long-term storage, as it were. But each non-REM and REM, they seem to have different functions, and we can only speculate, and it is speculative what's going on. I have my own theories about it, but so it's really it's people who say they dream a lot probably don't dream a lot. They actually wake up during their dreams, and people who say they never dream just sleep through the dreams and they wake up out of non-REM sleep and they never remember their dreams. But almost everybody will have both non-REM and REM sleep.
Hmm. So is the stage of the REM stage, is that the last stage for everybody?
Well, it will be the last stage if you have a regular schedule and you're waking up spontaneously or because your circadian rhythm is well synchronized. So that would be where you would awaken. And REM sleep, contrary to what people think, REM is actually a very light stage. The transition from REM sleep to wakefulness is instantaneous. So, as a physician, Glenn, you'll probably remember this from your years uh, of being on call. Um, if the hospital calls you and you're dreaming, you'll make the transition from the dream stage to wakefulness very quickly. You literally hit the ground. Your brain hits the ground running. If, however, they call you early in the night when you're in that deep stage 3 or N3 sleep, um, you will you will sound to the nurses like you're drunk. You'll be confused, and it'll take you a while. There's a sleep inertia. It takes a while to wake up. And in fact, I was the director of the intensive care unit at our hospital. The nurses complained to me about one of the heart surgeons. They thought he was drinking, that he had because he sounded drunk when they when they called. But what fortunately, I was actually a sleep doctor at the time, and so I knew this. So I asked about what time they called, and I figured out that they'd called him probably within an hour of him falling asleep, and they caught him in deep sleep, and he just was having a hard time. It takes a while to wake up, and I can remember from my training waking up and uh, responding to the nurses, and then kind of going back to sleep, and suddenly remembering that what I said was totally inappropriate, and again and taking corrective action. So it does have its consequences.
Oh my goodness. Well, it's quite interesting because before, working in the film industry, especially in Asia, there's no overtime, and sometimes we just have to go for 36 to 40 hours straight. So you would try to get your naps or your sleep in between every shot that they were doing. And I could remember saying to everyone, we sort of trained our bodies to be able to sleep in between. So whether it be for the 20 minutes or the 45 minutes, I found the minute that I ever went over 30 minutes, I would hit that deep sleep. And it would be the worst thing to try to get me out of. And once I hit that, you have to sort of let me go for the next 3 hours, or or I'm toast, you know.
Your observations are exactly right. In fact, we tell people um, if they're going to take a nap because they have to, and they should, if they're especially if they're driving and they're too sleepy, I rather them pull over and take a short nap. But I tell them to set their smartphone for 20 minutes because otherwise it'll be hard to wake up. And that's called sleep inertia. So you're absolutely right. And you don't train yourself to sleep. It's not, you fall asleep when you're sleep deprived. The pressure to fall asleep is so good, so high that you will be able to fall asleep. I get a lot of when I had a lot of veterans, especially years ago when we still had the World War II veterans around, and they would be very sleepy, and they would say they trained themselves in the army to be able to nap anytime, and they thought that's why they were able to nap all the time. Of course, when they were in World War II, they were napping because they had to, and that's the only sleep they got. They were sleepy now for other reasons, but they were thinking that it was just a holdover from their time in the military, and there are many holdovers from the military, but the sleepiness does not hold over. that's because they have developed a sleep disorder. In fact, that's my rule of thumb. One rule of thumb is that if you're excessively sleepy, that is, you get sleepy when you're driving a car, or when you're watching TV or reading a magazine, when you want to be awake. Um, if you're that sleepy, or if you are sleepy, then you have a sleep disorder by definition. It may be insufficient sleep, but that's sleep disorder. That's not. So then you have to investigate, why are you sleepy. That's probably, to me, that's the most important symptom of a sleep disorder, is excessive sleepiness. Uh, it's a manifestation of some primary sleep disorders, and it's a consequence as a secondary fashion of other sleep disorders.
Mm-hmm.
Can you give us a definition and a reason for sleep, and then we'll go on into some of these sleep disorders?
Yeah, yeah. I think that somebody said, I like the way somebody phrased it. One of my colleagues in the field said that sleep is of the brain and for the brain. Um, we sleep, as I say, it's a necessary function, and it probably is to restore and maintain brain function. My theory is that uh, the brain needs to recover from all the activity, needs to restore some of the neurotransmitters and restock, as it were. And the body, the muscles, and everything else also need an opportunity to slow down and recoup, rebuild, restock the muscles with glycogen and so forth. So there are some processes, endocrine things, which are linked to sleep. I think that also REM sleep, and to some extent non-REM sleep, probably is also part of the learning process. Learn new things. These pathways in the brain have to be established in a more permanent fashion, and I think that we're constantly remodeling our brain, and I think a lot of that goes on during sleep. So the consequences of not sleeping is probably impairment in your cognitive function. And I think that's a big area which uh, needs to be recognized more, that uh, if you don't sleep, you're not only sleepy, but often it changes your mood, and it changes your ability to think, changes your memory. So, uh, so simplistically, if you don't sleep, you're sleepy and you're impaired. Um, but I think that it's very complicated. It's a very complicated process, and when we don't sleep, in addition to the cognitive impairment, there are metabolic consequences. It activates all the stress hormones and really probably affects everything from immunity to uh, to heart attacks, stroke, and so forth. So it's actually, that's why I think we're beginning to understand it's a key risk factor uh, in our general health.
Yeah, very important on all levels. Would you give us just a moment or two on the chemistry of sleep, and waking? What makes us go to sleep, and what makes us wake up? Where's that balance? We found that out, haven't we?
Yeah, I think that this is actually it's a very important question. I'll try to uh, explain it clearly. There are two processes. There's the drive to sleep, which is entirely driven, we call the homeostatic drive. It's basically, the less you've slept, or the further away it's from the last sleep episode, you build up a drive to sleep, the homeostatic drive. And this is so so by the evening, well, I should say by night, by the time to go to sleep, you have built up a drive, and this is called the homeostatic drive, and it's probably the primary chemical is adenosine. Adenosine is it's, as you know, everybody heard of ATP and ADP and so forth. The energy compounds. Well, the more we're up, the more adenosine builds up in our system, and the direct antagonist, chemical antagonist of adenosine, is coffee. So that's why coffee and caffeine works. It basically is an inhibitor and a blocker and antagonist of the homeostatic drive to sleep. So we have sleep deprivation promotes a drive to sleep. Opposing that is the circadian mechanism. Circadian means circadia, around the clock. It's the 24-hour internal clock that we have, which unfortunately is not exactly 24 hours. Now, I don't know why it's not 24 hours. It's because the Earth's rotation was different when we were cavemen and prehistoric, and but it's a little longer than 24 hours. And this cycle is in the part of the brain called the suprachiasmatic nucleus, the SCN, we call it. And this is where our clock resides. And basically, it's a clock that is like, I liken it to a 24-hour hourglass. In other words, imagine an hourglass that takes 24 hours to empty, and then you have to turn it over. And that's kind of what's going on. There's some RNA transcription and protein synthesis, which I won't go into, but it takes 24 hours and it starts over again. And this clock, because it's not 24 hours, if we are left to our own device and don't have any structure to our sleep, you will tend to sleep in a little later every day. Now, people whose clock runs at 24 hours, they are close to 24 hours, they have a fairly regular thing. They're morning people. People whose clock runs slow, they're night people. They're night owls. And if they don't reset their clock every morning by, influence of daylight, they get into trouble. So the circadian mechanism actually tries to alert us. It actually tries to keep us awake. So as we're getting more and more sleep deprived during the day, our circadian mechanism, our core body temperature is gradually increasing and is trying to compensate for the fact that we otherwise would be very sleepy. So depending on how effective your circadian mechanism is, you can actually work a full, 16 hours during the day, and then your circadian mechanism about an hour and a half before your bedtime starts to pull back. Your core body temperature drops, and then the sleep drive starts to take over and let you go to sleep. That's if everything is working right, and if your rhythm, your circadian rhythm, is properly aligned with your life. That doesn't happen that often these days in our modern culture, and that is the source of a lot of sleep disorders. So two competing drives, one that makes you sleepy and one that's trying to wake you up. And if they're aligned, it works fine. But if it doesn't work fine, the chemicals for that for the circadian mechanisms are less well known. We think it's probably related to one of those chemicals that we know is called orexin or hypocretin, and that's the chemical that's missing in people with narcolepsy, and that's being elucidated. And the other chemicals that keep us awake or that wake us up are the adrenaline type chemicals, and there are a bunch of mediators in the brain that the rest of the body do opposite things, but in the brain wake us up. For instance, for Glenn and people who know this, acetylcholine and epinephrine usually are opposed chemicals, but in the brain they all are wake up chemicals. And so we have serotonin, dopamine. These are some of the other histamine. Histamine wakes us up. That's why antihistamines make us sleepy. So that's why the new antihistamines are designed so not to get into the brain or to have less ability to actually get into the central nervous system. So it's been a fascinating puzzle to put together, and they're making great progress in it. It's none of the stuff was known when I was in medical school. It's all new.
Right, it is all new. What are some of the misconceptions that people have about sleep that you can correct us on?
Okay. I think the biggest one is that we need less sleep as we get older. That's wrong. We actually don't need less sleep. We're just able to sleep less well. um, so we start life when we're an infant and a toddler, we do need more sleep. And interestingly, 50% of as I said, 50% of our sleep is REM sleep. By the time we get to 22, our age of 22 or so, our requirement sleep structure is actually fairly stable. And as life goes on, we get less deep sleep. We're able to get less deep sleep. Um, and but what happens is, whereas when you're 8 or 9 years old, you sleep dead, and when you're awake. Nothing can put you to sleep. Even a physics lecture delivered by a Hungarian physicist with a thick accent in a dark warm room wouldn't put an 8-year-old to sleep. Put
Were we
everyone
in the same medical school together? I had that professor.
professor, right? Right. Um, so uh, if you look around in a college class, college lecture room, 50% after lunch, 50% of the people in the lecture hall are asleep. All right. So and that's because once they get to college, they do everything. The college students do everything wrong. We can go into that. That's actually one of the sleep disorders I will talk about. I can talk about, but um, so an 8-year-old, when they still have the mistaken notion that they have to listen to their parents. They actually, you know, they actually, have a regular routine, and the parents, run, run a tight ship, and the kids get enough sleep, so everything works great. And the rest of our life, things start to fall apart. The kids, the college students, of course, just do everything wrong, but they were otherwise healthy. And as we get older, we start developing problems. We get put on medicines, and everything starts to interfere with the sleep process. Work schedules, and so it basically things do deteriorate. But we still need the same amount of sleep. So, my 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 wife's mom used to say, "I only need 5 hours of sleep," but she would be sleeping, in between courses at dinner. Her head would be in the soup, and so sleeping in front of TV and so forth. So they're sleeping. They need the amount of sleep. They just can't consolidate it. Like you can when you're 8 or 9 years old. So that's a big conception. And then the other one, as I mentioned, was that you can train yourself to function and be fine with less sleep. That's also a misconception. And there are many others too. Which um, Glenn, do you have any myths that you've heard that you wonder about?
Uh, there are many, but I think it's a different show.
Well, that's really interesting because I have to say that for whatever it was, growing up, my family always wondered how come I wouldn't need as much sleep as everyone else in the family. I have 5 other siblings, and I was the only one. After 5 hours of sleep, I'd be bouncing around like this, like this jumping jelly bean, and yet I would consume more food than any of my siblings, and they would, so it wasn't. And they said I had tapeworms. Two, they said that I was on an adrenaline rush, and what was I taking? And literally any more than 6 hours of sleep, that would be I would like fall, almost like I would be lethargic. If I got 8 hours of sleep like my brothers, I would be lethargic for the rest of the day. So that was something that was very curious. And so would that be a disorder?
Well, the the number of people who are truly short sleepers that are truly sleep repleted with 5 or 6 hours are actually pretty rare. They probably occur, but it's possible. Another possible explanation might have been that your circadian mechanism was set. You got up at a certain time, regardless of how much sleep you got. That's normal. I mean, that would be good. In other words, if you get up at the same time every day, get enough daylight to set your clock, then you were up. And then you may have been just keeping yourself active and stimulated at a time when you should have been sleepy, but were kept yourself going. Kids do it with video games, just activities which actually make them miss the window of when they're really ready to go to sleep. So I think that, and I think that what was happening to you, if you'd sleep late, you were sleeping in, then you were in a sense getting into that sleep inertia we were talking about, where were compensating for your um, sleep deprivation, but you were doing it out of sync with your circadian mechanism. So you were a little misaligned. So probably my guess is that you were not initiating sleep when you should have, but you were getting up according to your well-defined, well-established circadian wake-up time, which is good. So, and then I think you really are on adrenaline, because if you don't get enough sleep, you're using your flight mechanisms to activate yourself and to keep yourself stimulated. And it's I think that kids, for instance, and this is another issue, kids who are um, have a sleep disorder, either not enough sleep or they have disrupted sleep, they will be hyperactive and they will be often correctly with as attention deficit disorder. And whereas an adult falls asleep, a kid who's sleepy will actually present as a behavioral issue. And so we now know, and it's been well established now that a lot of kids who've been diagnosed with ADHD actually have sleep apnea, um, the most common one from big tonsils. Uh, so I think that my caution to general doctors, psychiatrists, and the public in general is that when your child is being diagnosed with attention deficit disorder, um, that's fine, but consider a sleep disorder first, because Ritalin or a stimulant will certainly combat the sleepiness and make them function better, but it's still not a substitute for good sleep. So I think that that's been an area which has been particularly interesting. Um,
Hmm. Oh, how interesting. I must be completely off alignment. First, I have this thing where I can't, I don't need as much sleep. Then I get diagnosed with apnea as I get older. And now what you're telling me is children are diagnosed with apnea as well.
yes, most, you know, when you look at a kid, you'll notice a young kid. You'll notice one, they have a very small jaw. They have their chin is, it takes a while for the jaw to grow. So that, and if you have a kid who perhaps also has had some um, nasal allergies and so forth, they're mouth breathers. So the palate doesn't form correctly because they're sleeping, breathing with their mouth open because their nose is stuffy, and so the tongue is not serving as a mold to mold the palate, and so the teeth get moved around, and then they combine that with big tonsils, and they have obstructive sleep apnea. And some may grow out of it, but a lot don't. And they so I think that more and more dentists and pediatricians need to be uh, aware of this. When we were kids, I think probably when Glenn and I were growing up, everybody had their tonsils taken out. Those were routine. Then they went the other direction. And the nurses in the intensive care unit used to come to me and say, "Gee, my kid snorts and snores and so forth and so forth." And I took him to the pediatrician, wondering if his tonsils should be taken out. And they said, "Nah, they're fine." And I'd say, "No, they're not fine. If you hear him snoring, go to the ENT guy and take him out." That may not cure it in every kid, but it's a start. And so I think that, and a lot of these nurses would tell me that the kid's behavior changed too. And there was just a study published, and it hadn't been published, excuse me, it was delivered at a meeting where they showed they now have neuroimaging, which shows that these kids with ADHD, with sleep apnea, and they did both neurocognitive testing and neuroimaging, and then treated them and showed the reversal of both of the improvement in executive function and changes in the brain function once the sleep apnea was corrected.
Wow. That's
Andy,
amazing.
That's a real deal.
Yeah.
Andy, in that one question, you got 5 wows from Christina.
Because I'm always fascinated with children. I'm always fascinated as, I have a 5-year-old, so I watch, and he sleeps by my bed. So his bed is connected to my bed, so to say. And I've watched him since birth, going through all the wonderful yoga poses naturally and watching him sleep. Because, again, in my family, allergies and things like that, and asthma was very high, ran very high in my family. And I just watch and make sure that everything is great at night and things like that. And if there's any sound or any stoppage, I am there to be sensitive to that. And I'm just fascinated by the way they breathe, by the way their stomach breath shifts into the chest, and when they're breathing from their mouth and when they're snoring and not. And I just find it fascinating. And when I was diagnosed with sleep apnea, which was like 12 years ago, they were saying, well, I'm only 110 pounds. I'm pretty lean. And at that time they were questioning why I had it, because I wasn't a heavier set person. I mean, now it sounds like the studies have gone so far, the studies that you've been doing, Dr. Binder, that is magnificent. But now to hear that it affects children as well, that's like a wow. That's a big wow to me.
Well, actually, the fact is that Asians, because of their facial structure, often do have that are prone to sleep apnea. You go to Japan, where nobody's overweight in Japan, and they have a very high prevalence of sleep apnea because of their facial structure. And I had a patient, an Asian man, who he must have weighed 98 pounds, as an engineer, and he had his apnea hypopnea index was uh, was 88 per hour, 88 interruptions in his sleep per hour.
There's another wow.
So,
Do sumo wrestlers have
you
apnea?
know, well, they had the double whammy because because they're Japanese and they're overweight. So yes, I would imagine they do, but I haven't seen the study. I'm sure there's one published out there, but I haven't I don't know it. But yeah, and then of course then we have the NFL football players. We know
All
about.
right, Andy, we've talked about the order of sleep with the cycles, circadian rhythms, homeostasis, and waking and sleeping. Let's get into the disorders. I'd like to know, how many disorders are there? What's the most common? What's the most bizarre? And then we'll start talking about diagnosis and treatment. But give us a little bit of the disorder of sleep.
Well, I love this field because uh, we actually categorize the sleep disorders in 6 groups, and that's a manageable number. In other words, it's not overwhelming, and it's the way you should approach sleep disorders. So they are, and this is not in any particular. This is just the way they come to my head. First, there's maybe the most common or prevalent complaint is insomnia. So we have a group of insomnia. Then we have, by contrast, we have the hypersomnias, that's disorders of excessive sleepiness. So we have the insomnias, which are basically defined as difficulty initiating or maintaining sleep. And then we have the hypersomnias, excessive daytime sleepiness. Then we have the sleep apneas, or the sleep-related breathing disorders, and they come in a range. Then we have that's 3. Then we have the sleep-related movement disorders. That's restless legs and periodic limb movement disorders, and a few others, but those are the most important ones. These are types of involuntary movements during sleep, which may affect your ability to maintain sleep or go to sleep. Then we have the circadian rhythm disorders, which we alluded to, and that the most common one would be college students who stay up till 3 or 4 o'clock in the morning and can't get out of bed till 12 noon. But others that fall into this category would be like jet lag and shift work. Right. So these are where people are basically living their lives out of alignment with the rest of the world, or what their work or school schedule should be. And then finally, we have the parasomnias. And the parasomnias really are very interesting, because these are the unwanted abnormal behavior during sleep. So sleepwalking, and it comes in a variety. Sleepwalking comes in a variety of flavors. There's REM and non-REM sleepwalking, or parasomnias, and then you have sleep-related eating. You have all of, and then you have one other one. Well, forget that. So you basically, that's the sleepwalking, sleep eating, sleep talking, um, and sleep eating. Those are all the parasomnias. So that's kind of the 6 broad categories within them, and that's pretty. Once you think about it, it's really easy to address it, because typically I see people that almost all of them have at least 2, at least 2 at a. Yeah, they almost always have 2 at a time. Yeah.
I think I've lived all 6.
How do you how do you get sleepwalking in REM sleep if you're paralyzed?
Well, that's it. That's exactly it. It's called that. This disorder is called REM sleep behavior disorder, and like like all of biology and physiology, you have an established mechanism that's supposed to protect you, and sometimes it doesn't work. So the the inhibition or the paralysis of the muscles is an active process by the brain. It's mediated through a chemical called glycine, and basically it inhibits the lower motor neurons during REM sleep. That's part of the process, and it breaks down. Um, so people will act out their dreams, and they can be and when they're acting out their dreams, there's kind of a positive feedback. So the dreams get more and more vivid and more active. So they'll be punching and they'll be reenacting fights and their bed partners will think that they're sleeping next to um, a serial killer or something. Right? Uh, uh, and it's there, the person may be the most mild mannered, easygoing person. At night they have these violent dreams. So this concern and the initial thinking was this psychological? Was this a you know post-traumatic stress disorder, which often it gets misdiagnosed? And you have to distinguish it from seizures. But it actually is a it's not the best. And here's where the audience may get a little bit um, concerned. It's actually when it shows up in late or middle age, and it's more common in men, it's often a precursor and can actually precede the onset of neurologic disorders by 10 years, most commonly Parkinson's disease. So when you see it, you're kind of, as a physician, sleep doctor, I'm a little bit in a bind because I don't want to tell the person, oh, by the way, you may develop Parkinson's disease in 10 years. But if I don't tell them, they're going to look it up on the internet and find that out. So I have to tread very carefully about that. But you have to distinguish it from seizures and some medications. A lot of the antidepressant medicines, in fact, most of them, sometimes um, are associated. In other words, it becomes evident once they get started on those medicines. And we never know. We're not sure, is it really unmasking a disorder causing it? And that's a debate and a controversy that we don't have an answer to yet. But frequently somebody gets started on an SSRI like Prozac or the son of Prozac, any of those medicines, and Effexor, and they start having this behavior, and it correlates with when they started it. So but it's something that physicians need to know, and it is very different. But you do have to do a sleep study to make sure that it's not a seizure and make that distinction and make sure that it's really not regular sleepwalking, which occurs out of non-REM sleep, which is more of a confusional arousal. It's a partial awakening where you wake up halfway and you do things you don't remember. The people with REM sleep behavior disorder, they know they're acting out their dreams. They wake up and they said, oh, I thought I was somebody trying to fight me. Do you know when you dream, all of you have experienced, I think, a dream where you're trying to accomplish something and you can't get it done. There's a certain frustration, and that's because of the paralysis. That's because you can't run fast enough because your muscles won't move. So you're trying to move, you just can't, like the dog that's twitching. Um, and a nightmare is also a parasomnia. A nightmare is just a dream gone bad. Um, you know, part of it, it, part of the REM sleep physiology um, is actually sexual arousal. In men, this is much more obvious, but this is where tumescence occurs, right? So, and that's and so dreams will often may have a sexual content, but because of the paralysis of your intercostal muscles, the breathing muscles, when you're in dream sleep, the only muscle that breathing is your diaphragm. Your normal chest muscles aren't working, and um, so people sense a weight on their chest, and they can't breathe, and they feel often, and then they may feel they're being uh, attacked, sexually attacked. And in art, you'll see the incubus and the succubus. Those are demons, which are portrayed in paintings of a demon sitting on the woman's chest or the male chest. The incubus and succubus are the male and female versions of it, and that's actually a an artistic rendering of a nightmare, basically, and it's all relates to the actual physiology of REM sleep.
Hmm. We had a conversation with Ravi Bosnak, and we talked about dreams and dream work. Be interesting to have both of you on to talk together about the dream process. So, so now people are out there, and people are hearing about sleep problems and sleep disorders. How does someone, if they don't have a partner, or if they do have a partner, how does someone figure out that they should go to a sleep medicine physician? And what happens when you do see a sleep medicine physician? Tell us a little bit about how you how you work in the sleep clinic.
Okay, I'm glad. I am glad you asked that. First of all, as I mentioned earlier on, if you're excessively sleepy and it's not obvious why you're sleepy because you think you're getting enough sleep, um, then you have a sleep disorder, and you should that individual should request from their physician a referral to a sleep physician, not a sleep study. I really would want to uh, discourage the practice of going from a primary physician to a sleep test, a sleep study, sleep lab. They should go to see a sleep physician first. Now, um, so that's the first thing. So if you're sleepy and tired, I always say there are three kinds of tiredness. There's tiredness as in being sleepy. There's tiredness being physically unable to do exertion, like you get tired going up a hill or climbing stairs. And then there's everything else, the tiredness of, just no motivation, just not wanting to get out of bed. Now, these three kinds of tiredness are not mutually exclusive. Um, you can have all three, but the etiologies, the cause of these three are very different, and the treatments are different. So you need to pin it down and dissect it. So if a person is sleepy, that is, they can and will take a nap given the opportunity, then they're sleepy. And sometimes the explanation is very obvious, like they're just not getting enough sleep. They're just, or they're doing shift work. But if they don't have an obvious explanation, then you need to find it. So that's the first symptom. The second symptom of sleep complaints is, of course, insomnia. People who just say they have a hard time sleeping. And I will also uh, caution people to realize that sometimes when they're sleepy during the day, they assume they have insomnia, and they will come to see me saying that they can't sleep at night, but in fact they sleep fine. They're not they going to if they wake up during the night, they go back to sleep quickly. They Their problem is that they're sleepy when they wake up, and so they assume that they're not sleeping well at night, and that may be true, but that's not insomnia. So insomnia is another complaint which has very multiple uh, issues related with insomnia, mood disorders, and so forth. It's probably our most difficult disorder to treat. Um, but uh, the other reason to go to seek out help is if you don't know if you have a problem and nobody's witnessed it, but if you're at high risk. So think about the associated symptoms or associated conditions with sleep apnea. Um, Often, and again, uh, uh, hosts uh, exception, but often overweight, um, high blood pressure, getting up at night to urinate, acid, acid reflux or acid indigestion, decrease in sexual interest or function. Those are all symptoms not of middle age, but actually of sleep apnea. Now they're not. That's not the only cause of it, but those are common medical complaints, and every one of those is associated with sleep apnea. And the other group would be the people, Glenn, who have unexplained atrial fibrillation. In other words, they don't have known heart disease, they haven't had a heart attack, they don't have a bad heart valve, but they present suddenly an otherwise healthy person that develops atrial fibrillation. Then you should think about sleep apnea as a possible cause. So even if they don't have obvious symptoms, except for those other uh, associated symptoms, they should at least consider it and see and perhaps see a sleep physician and then uh, see if it's worthwhile to do a sleep study.
Tell us about the sleep study.
Okay. Well, The sleep study is usually done, although I'll talk about the home studies, but a sleep study is usually done in a sleep center or sleep laboratory, and the patient will come in, um, and I advise the patients, except under specific circumstances, whatever medication they're taking, they should continue taking, even if they're taking sleeping medicines. We want them to study them as they are in the real world. And they come to the sleep center, and we hook up a lot of electrodes on their brain. I mean, not on their brain, excuse me, on their scalp, and reading their brain waves. And we also have sensors around the eyes so we can detect their eye movements. And then we have electrodes around their chin, their face, so we can see their muscle tone of their chin. And then we have sensors around their chest and their abdomen to sense when their chest and abdomen are moving. They're wearing a little cannula to register when air is moving in and out of their nose and their mouth. That usually measures pressure, sometimes also temperature. And then we have an oximeter, which is a little device that is usually hooked to the ear or the finger, that basically through the skin can detect the level of oxygen in your blood. Then we have electrodes on your legs to detect muscle movements. But all these things are bundled in such a fashion as to be amazingly, surprisingly unobtrusive. So the patients, some of them feel they can move, but if the technician does the job right, the patients can move, roll over, do everything. But the technician's there if they happen to pull off an electrode and can replace it. And if the patient has to get up at night to go to the bathroom, there's a quick disconnect harness which they can disconnect, go to the bathroom, get back, and just don't have to reapply all the electrodes. And we basically watch them for, you know, 7 to 8 hours, and uh, and see if they have disrupted breathing, and or if they have some other abnormal movements, seizures, things like that. And if they have severe sleep apnea in the middle of the night, once we've established that that is their problem, the technician has a protocol where they will actually apply the first line treatment for sleep apnea, and that's that pressure device called continuous positive airway pressure, or CPAP, or some derivation of CPAP, to see if they can correct it. So we call that a split night study. Sometimes we have to do it in 2 separate nights. Sometimes we can do it in 1 night. You recognize, as I mentioned, sleep is not symmetrical. The first part of the night is dominated by deep non-REM sleep, and the second half of the night is dominated by lighter non-REM and REM sleep. And it turns out sleep apnea gets worse the second half of the night. So sometimes you don't see much sleep apnea in the first part of the night, and it shows up the second half of the night, and therefore you can't apply. You don't have time to apply CPAP. So that's kind of a quick overview of the sleep study. We don't usually do sleep studies routinely for insomnia. We only do that after the initial treatment and behavioral changes don't work for insomnia. Then we'll go ahead and see if we're missing
So
something.
you can bring your blankie if you have to your sleep clinic. Someone sleeps with their own little blankie or their wimpy or something, or their teddy bear. They can bring that, right?
Yes, we encourage them to bring their favorite pillow, their teddy bear, and so forth. The only thing we don't let them bring is their spouse.
Okay, so uh, melatonin, lemon balm, L-theanine, valerian extract, hops extract, zero gravity beds, adjustment beds. Do these work? Are they good? What should we think about?
Okay, well, I'm going to start with melatonin. Melatonin is the mediator, and I can't believe I failed to uh, to mention this when I talked about the circadian rhythm. The modulators of our circadian rhythm are daylight and melatonin. Sunlight inhibits our pineal gland from secreting melatonin. So darkness encourages the secretion of melatonin. So melatonin is both a weak hypnotic, and it's also our timekeeper. It basically, so when we have patients who are blind and are unable to synchronize their clock with the of light on the retina going through the normal pathways through the suprachiasmatic nucleus, um, we um, we actually you give the blind people melatonin at a particular time. So if you want to synchronize somebody to go to bed at 11 o'clock and wake up at 7 a.m., that would correspond to a very low dose of melatonin. I'm talking like a half a milligram to a milligram. Um, you give that at around 8 p.m. And in the blind patients, over time, that will entrain their circadian clock to an 11/7 schedule. So um, it's so melatonin has its use, I think, as a timekeeper. It's relatively weak as a hypnotic. Um, but valerian has been studied and probably is a very weak hypnotic. The other ones, I don't have enough information on those. I hear stories, anecdotes, and so forth, but I always point out that if there was a great sleeping medication, a great hypnotic, we wouldn't have so many. All right, there would only yeah. So we don't have great hypnotic. They all have their pluses and minuses, and they have their uses, and they have their abuses. So I think that they very few of them ever work successfully long term without making other changes in the person's uh, sleep behaviors and habits.
Is there a harm in taking melatonin every day?
Um, I don't. It's a good. It's somewhat an unanswerable question. I think that a low dose melatonin taken every day is fine, um, but as I said, you should take it at the appropriate time because that is appropriate to your schedule. Now, if you have no trouble with sleep and you keep a regular schedule and you take it right at bedtime, it's probably not doing much because your body's already secreting a lot of melatonin. And there was some concern at very high doses that it may have some effect on the gonadotropins, the testosterone in particular. So that that is unclear right now, but its structure has it is a neuro it's structured as a neurotransmitter, and therefore there can be some overlap with it. But I think in low dose it's probably safe, and I think it has a real use in helping people. I use it a lot to try to help people realign their their sleep-wake schedule. There's some very complicated schemes for how to use it to help with jet lag and things like that, traveling. That's fairly complicated, actually. The circadian mechanism, how to intervene and modulate it, is actually very tricky, and it's often neglected even by my colleagues in the sleep field. It's misalignment of the circadian rhythm is really very frequent as part of the etiology of insomnia, and I guess the way to say that is people who have to get up early for work uh, on the weekday, and then they're sleep deprived because of the demands of their busy life. They sleep late on weekends, so it really screws up their circadian mechanism. And so they uh, they if they sleep to 9 or 10, but they during the weekday have to get up at 6 a.m. Um, then they can't go to sleep at night at at 10 because their body really thinks they shouldn't be going to sleep till midnight, and the body that circadian mechanism is an alerting mechanism. It actually that so-called second wind, just when you're supposed to think you should be going to sleep, suddenly you get a burst of energy, and that's your circadian mechanism in action, which gets its strongest before it starts to recede, and that's a big problem. So you have to kind of address that, and it's very tough to get people to change their habits. It's very hard to talk somebody out um, of changing, taking away their ability to sleep late, and try to do it to your kids. Wait, just wait till you have a teenager. I got to tell you, my girls were swimmers, and come the summer, they wanted to stay up late, and on the one, they'd want to sleep late. But fortunately, the coach was the bad guy, uh, so I only had to be the heavy, uh, for part of the year on the summers. But it is a major battle with the kids.
You're not saying that having children is a sleep disorder, are you?
Yes, it is.
That's a whole other category. Listen, Andy, with all of my guests, our guests, we always ask a health tip that you can share with us, something from your experience and your expertise. Do you have something you'd like to share with us today?
Well, uh, the first thing, I guess, maybe two things. One is that, um, um, you read in all the self-help magazines how it's important to have a regular sleep-wake schedule. People interpret that meaning they should go to sleep at the same time and wake up at the same time. Go to sleep when you're sleepy, and hopefully give yourself enough opportunity to get sleepy. But you should wake up at the same time by the clock because you have to reset your clock every morning. So going to sleep by the clock can just be a frustration because you may not be sleepy because for whatever reason, and getting in bed and not falling asleep is just frustrating and creates anxiety and frustration. But you should get up at the same time, and if you had a short night because of you were up late for whatever reason, my recommendation is either make it up by going to bed earlier the next night when you crashed in bed, or take a short nap during the day, but don't sleep in.
Oh, that's interesting. That's a great tip because that was on my mind. Like, what am I going to ask you? Well, and look, can you see Glenn on the screen? He's decided to take a nap on us.
I do that to a lot of people. I put them to sleep, um, but uh, the second tip really is I mentioned it before. If you think you have a sleep problem, don't let your doctor send you to a sleep study. Encourage them to send you to a sleep doctor because I think that a sleep study without some um, evaluation of why you're doing the sleep study um, is often going to be misleading or frustrating. For instance, I've had people sent to the sleep lab um, directly, and they were uh, they were shift workers, so they normally are awake at night. So so you want to know those things before you go to the sleep lab because they're not going to be able to sleep. You're going to have to make some accommodation. And we used to do that. We actually sometimes for our people who are truly night people, not just uh, swing shift, but graveyard shift. Who really were truly night workers, day sleepers. We actually would do some sleep studies, full on nighttime sleep studies during the day. We were set up to do that.
I would like to thank our very special guest, Dr. Andrew Binder, for sharing his expertise and wisdom with us. I would also thank all of my healers and educators and teachers throughout my life. I look forward to sharing another adventure in the healthcare galaxy next week. And until next week, I wish you all optimal health. Thank you, Andy.
Thank you, Dr. Binder. It was a lot of fun. We have to get you back.